drug-induced hematological disorders. Objectives to be covered in the lecture. The first one is mention the most common hematological disorders induced by the drugs. Second one, enumerate the common drug that induces the hematological disorders. Third one, explain the common mechanisms of drug-induced hematological disorders. And the last one is the management and the treatment of the drug-induced hematological disorders. Let us see first one. Mention the most common hematological disorders induced by the drug. In another term, it is also called as blood dyscrasias. Blood induced hematological disorders, sorry, drug induced hematological disorders, as the name indicate, it is self explanatory. The hematological disorders which is caused by the drugs, the common drugs which is generally used in the common infection and the common prescribed drugs. There are so many drugs which are responsible for the hematological disorders, but we will see only some common one. So first, which are the most common hematological disorders? There are four most common hematological disorders. The first one is aplastic anemia, which indicates the generally there is bone marrow fails to produce RBC, WBC, and platelets. And in another medical term, it is also called as pancytopenia. Pancytopenia, when the bone marrow fails to produce RBC, WBC, and platelets. Aplastic anemia. Second one is hemolytic anemia, and it is generally specific to the RBCs, which leads to the destructions of the RBC. Third one is agranulocytosis. The another medical term for the agranulocytosis is neutropenia, or we can say reduction in the neutrophil count. And the fourth one is thrombocytopenia, in which generally the decrease in the platelet count. So these are the four hematological disorders today we will discuss as per the objectives. And I hope you are aware of this aplastic anemia, hemolytic anemia, neutropenia, and thrombocytopenia in relation to the pathophysiology. First one is aplastic anemia. Here, if you see the purple color, you can click on this purple color title or the word. You are directed for the further reading, or you are directed for the some references, important one. Suppose this example, suppose I will click on this aplastic anemia. This is the purple color. We will move towards the landing page of the further information by the Medscape. It's loading slowly. It's loading slowly, yes. Okay, let them to load. We will move towards the. So if you click on this purple color words, you are getting the further reading references. You can read for get the extra knowledge, extra benefits. Aplastic anemia. What is the mechanism of drug-induced aplastic anemia? How the drug induces the aplastic anemia? There are three main mechanisms: direct dose dependent drug toxicity, And the most common drugs are anti-cancer drugs and the radiotherapy, we can say. Direct dose dependent drug toxicity, as per the name, it itself explanatory. If the dose is excess, it may causes to the damage to the cell, and these cells may be RBC, maybe WBC, maybe platelets. So it's depend on the dose. If the dose of the drug concentration is increased, it may responsible for the toxic effect to the cells. And most of the we know that the anti-cancer drugs, the aim of the anti-cancer drugs is to inhibits the production of the cell by the inhibiting the nucleic acid synthesis. So these anti-cancer drugs are not specific to the specific cell. They can also leads to the inhibition of the RBC, WBC, and platelets. So the direct dose dependent drug toxicity, it may be due to anti-cancer drugs and the radiotherapy. Second one is idiosyncratic and operate through toxic metabolites. Toxic metabolites, the every drug undergoes the metabolism, and after metabolism it produces the metabolites, and most of the drug having the toxic metabolites, which may leads to the destructions of the RBC, WBC, and platelets. And the examples are the chloramphenicol. Chloramphenicol is antibiotics and generally inhibits the protein synthesis in the cell, in the microorganisms. So idiosyncratic and operate through the toxic metabolites. The most common drug is chloramphenicol and generally responsible for the aplastic anemia. Third one is immunological response, and this immunological response is related with the antigen antibody reactions, which is produced by the use of some common drugs. Example: sulfonamides, sulfa drugs, antithyroid, and anti-epileptic drugs. Antithyroid drugs generally used in the treatment of hyperthyroidism, and anti-epileptic drugs generally used in the management of the convulsions, epilepsy. Uh, Sulfonamides generally leads to the aplastic anemia. It also responsible for the hemolytic anemia, and immunological reactions means it is generally acts through the antigen antibody reactions. Diagnosis: how can we diagnose? These are the diagnosis tests are available. CBC is the most important. Complete blood count, bone marrow biopsy, and if the WBC count of 3,500 per cubic millimeter or less, platelet count of 55,000 per cubic millimeter or less, or hemoglobin value of 10 gram per dl or less with reticulocyte count 30,000 per cubic millimeter or less. These are the lab values, and these lab values indicates the diagnosis of aplastic anemia. What is the treatment? The best, the most important first word for the all the treatment of the drug induced blood disorders are discontinuation of drug, discontinuation of causative drug. If the patient's diagnosis results indicates the any abnormalities in the blood cells, so the first most important one is stop the drug, we can say a discontinuation of causative drug. Next one is, there is two main treatment options here. Hematopoietic stem cell transplantation is a generally preferred treatment or treatment of choice if the patient is less than 40 years of age. So for your MCQ, there might be the question: the patient of the 35-year-old with aplastic anemia, and which of the following drug or therapy you will recommend? So hemopoietic stem cell transplantation is a treatment of choice if the patient is less than 40 years, and if the patient is more than 40 years, the immunosuppression, generally the anti-thymocyte globulin, is the first drug or preferred drug in the management of aplastic anemia. So please take a note about hematopoietic stem cell transplantations if the patient is less than 40 year, and take a note for anti-thymocyte globulin if the patient is more than 40 years. Another drugs are cyclosporine and the methylprednisone. If these are the purple color, and this purple color indicate, if you click on this purple color drug, you will be directed to the more information, more reference reading for the specific drug. Generally, methylprednisolone, it is a corticosteroid. Corticosteroids also recommended. Why? Corticosteroids reduces ADR, ADR adverse drug reactions associated with AGT, that is anti-thymocyte globulin administration. Also, cyclosporine inhibits the interleukin 2 production and release the subsequent activation of resting T cells. In summary, they will reduce the antigen antibody reactions by the immunosuppression actions. So these are the main therapy for the aplastic anemia. Hemolytic anemia. Generally, the hemolytic anemia is two types: immune hemolytic anemia and the oxidative hemolytic anemia. So, what is the mechanism of drug induced hemolytic anemia? The first one is drug induced auto antibody production. Drug produces the auto antibody and it leads to the antigen antibody reactions. These antigen antibody reactions are responsible for the breakdown of the blood cells, and specifically RBCs, and the methyl dopa is the example, most common example of this mechanism. Immune complex innocent bystander, that is the uh, quinine and the quinidine. In the last lectures, we discussed about the quinine and quinidine. These are the quinoline derivatives and main treatment in the management of the malaria, malarial parasites. Generally, this drug quinine and quinidine responsible for the tissue necrosis. Generally, cell necrosis. Quinine and quinidine is responsible for the cell necrosis. When the patient take this drug quinidine, they causes the necrosis to the cell, and we can say innocent bystander. They just standing the outside, but these are responsible for the cell necrosis and specifically to the RBC. Third one is heptane induced hemolysis. Heptane induced hemolysis, and examples are the penicillin and the cephalosporin. Now, what is this heptane induced hemolysis? I wish to add some point for this heptane induced. I will show you this. Yes, this is the first page of this. When we click on the aplastic anemia, it is landed here. I will show you what is heptane induced. Stay on the line. What is heptane? Heptane, a small molecule which, when combined with larger carriers such as protein, can elicit the production of antibody which binds specifically to it. Let us see the one image of heptane. Yes, see here, this is a heptane molecule and it binds with the carrier molecule which is having the high molecular weight, we can say the protein, and it is responsible for the complete antigen antibody reactions, that is the heptane. Let us go back to our lecture. Yes, and the fourth one is non immunological protein adsorption. There is no immunological reactions are involved in this mechanism, but the protein absorption on the drug may leads to the hemolysis, and the examples are the cephalosporin and the beta lactamase inhibitor. How can we diagnose this hemolytic anemia? The direct Coombs test, generally the direct Coombs test is used to diagnose the hemolytic anemia. Direct Coombs test or direct anti-human globulin test. This is in the pathological section. Diagnosis. Let us see about the treatment. Now the treatment is consists of two hemolytic anemia. The first one is immune hemolytic anemia, and the second one is oxidative hemolytic anemia. In the immune hemolytic anemia, yes, the first step is most important, discontinuation of the causative drug, stop the causative drug. Penicillin and other agents that can cause immune hemolysis should be discontinued in the patients who develop hemolysis. Generally, penicillins are responsible for the immune hemolytic anemia. And the following is a partial list of medication that can cause immune hemolysis. Which are these medications? Penicillin, antibiotic; cephalothene, cephalosporin, antibiotic; ampicillin, yes; methicillin, quinine, and the quinidine. So these are the antibiotics, and the quinine and the quinidine are the antimalarials. So these are responsible for the immune hemolytic anemia. And here the corticosteroid is most useful because when the words is immunity, immune system, so keep in mind the most important is corticosteroid. So the first choice you can give the corticosteroid here as a immunosuppressant. And if the patient is severe conditions, or we can give human anti CD20 monoclonal antibody, and which is rituximab. You can click on the this purple color drug name rituximab for the further reading. And blood transfusion is in the last option, or we can say it is in the additional non pharmacotherapy. The blood transfusion may be useful if the drugs are not get able to give some benefits. So the blood transfusion is also one of the most important way. So rituximab monoclonal antibody you can give, but the most important, remember, in the immune hemolytic anemia, corticosteroid. Oxidative hemolytic anemia and A hereditary conditions accompanies of glucose 6 phosphate dehydrogenase enzyme deficiency, and generally it happens with, as we discussed in the lecture of anti-malarial, generally the quinolin derivatives, the primaquine, tefenoquine. These drugs are very much responsible for the oxidative hemolytic anemia in patient with the glucose 6 phosphate dehydrogenase enzyme deficiency. The first step is discontinuation of the drug. Se- Second one, discontinue oxidant medications. Oxidant medications means the drugs which causes the oxidative hemolytic anemia, such as sulfa drugs. Sulfa drug means sulfonamides. In patient with glucose 6 phosphate dehydrogenase deficiency or those who have unstable hemoglobins. And this is the following is a partial list of medications and chemicals that should be avoided in glucose 6 phosphate dehydrogenase deficient persons. And these are the acetanilide. It is generally the having the activity of antipyretic, analgesic, anti-inflammatory. Furazolidone, isobutyl nitrile, nalidixic acid, generally used in the urinary tract infections, naphthalene, and nerirazole. These drugs should be avoided because it may responsible for the hemolytic, oxidative hemolytic anemia. And the best way, patient with these enzyme deficiencies should be advised to avoid medications capable of inducing hemolysis. And for this purpose, the health education is most important uh, aspect. Third disorder is neutropenia, or we can say agranulocytosis. There are generally two types, type 1 and the type 2. Two types of mechanism which induces the neutropenia or drug induced agranulocytosis. The type 1 is the drugs that affects the bone marrow and the DNA synthesis. Examples, high concentrations of the beta lactam antibiotic like penicillins, cephalosporins, ampicillin, amoxicillins, carbamazepine, and valproic acid, which is generally used in the management of epilepsy, quinidine, clozapine, and antithyroid drug. These drugs are responsible for the type 1 mechanism to induced neutropenia. Type 2 mechanism due to an immune mechanism, antigen antibody complex, blood immunoglobulins are directed against drug related antigens located on circulating leukocytosis. And again, type 2 is classified into three mechanisms. Type 2 is classified into three sub-mechanisms: heptene mechanism, immune complex mechanism, and autoimmune mechanism. What is the heptene mechanism? Drug or its metabolites bind to membrane of neutrophils or myeloid precursors, inducing antibodies formation. And the lysis occurs through the complement activation or through clearance from the circulation by macrophages. And examples are the aminopyrine, penicillin, and some gold salts which are used in treatment of arthritis. Immune complex mechanisms, it generally causes the antibodies form complexes with the causative drugs, and the immune complex adheres to the target cell, which leads to the cell destruction. And examples are quinidine and the quinine, which are the anti-malarial drugs. Third one is autoimmune mechanism. Generally, the drugs binds with the plasma protein, which leads to the which leads to the complex that fixates itself on the cell membrane of neutrophils. Production of the autoantibodies that react with neutrophils, complement activation, and which leads to the cell lysis. This is a part of the pathophysiology, and generally the example of drug is levamisole, which is generally used in the hookworm infection. How can we diagnose this neutropenia? Complete blood count, bone marrow biopsy, and if the neutrophil count is less than 500 cells per cubic millimeter. What is the treatment for the neutropenia or agranulocytosis, which is caused by the drugs? The first one is discontinuation of causative drug, the most important. Second one is, here we need antibiotic therapy to prevent the infections. If there is a decrease in the neutrophils, may leads to the infections, and generally the preferred antibiotic is the cephalosporin. Third generation cephalosporins are generally used to prevent the infections due to the decrease in the neutrophils. And in the most of the cases resolve when the drug stop. Most of the cases resolve when the drug stop within 2 weeks. And if it is not able to resolve, or in the severe cases, we have management plan for the neutropenia, and it includes two main drugs, sargramostim and filgrastim. If you click on the purple color drug words, you will be directed to the reference readings or extra readings. What is this GM-CSF? GM is granulocyte colony stimulating factor, or we can say granulocyte macrophage colony stimulating factor. The example of this granulocyte colony stimulating factor is filgrastim, and the example of the granulocyte macrophage colony stimulating factor is sargamostim. So this is your homework. You can click on the drug and you can read the information about the drugs, then pharmacology. Thrombocytopenia, the last hematological disorder. It is generally act by three mechanisms. The first one is drug. The first one is immune mediated mechanism. Second one is non-immune mediated mechanism, and the third, the most important, is heparin induced thrombocytopenia. Let us see the first immune mediated mechanism. Generally, the drug induced IgG to destroy platelet. Drug induce the this immunoglobulin, this antigen antibody reaction to destroy the platelets, and examples are the gold compounds generally used in the management of arthritis, procainamide, sulfonamides, penicillin, cephalosporin, rifampicin, glycoprotein receptor antagonist, which are generally used or which are generally antiplatelet. Examples are epsiximab or iptifibatide and the heparin. Second mechanism, non-immune mediated mechanisms. It is generally the direct toxicity to platelet or bone marrow. And examples are anti-cancer drugs. Most of the anti-cancer drugs, quinine, quinidine, and the gold salt, which are used in the management of arthritis. Heparin induced thrombocytopenia. This is most important. Heparin is an anticoagulant and generally used in the prevention of the deep vein thrombosis, in the prevention of the pulmonary embolism, and for the preventions of the thrombosis in the most of the cases during the surgery and after the surgery. Heparin induced thrombocytopenia, there is two types, HIT, heparin induced thrombocytopenia type 1 and type 2. What is type 1? Type 1 is the most common, occurring approximately 10 to 20% of the patient who treated with heparin. It is mild, reversible, non-immune mediated reaction that usually occurs within first 2 days of therapy, and it is usually an asymptomatic conditions and is thought to be related to platelet aggregation. Generally, most of the uh, common is a type 1, and it is generally due to the platelet aggregation due to use of the heparin to the patients, and the occurs into the 10 to 20%. HIT type 2, heparin induced thrombocytopenia, is a less common but more severe due to an antibody that binds to the complex of heparin and platelet factor 4, and it is an the immunological response, and it may leads to the severe reactions of the decrease in the platelet count. What is the diagnosis? If the platelet count is less than 100,000 cells per cubic millimeter, this is a complete blood count will be the diagnosis. And what is the treatment for this? Discontinuation of positive drug, stop the heparin, gold salt induced thrombocytopenia, that is prednisone. If the gold salt induced thrombocytopenia, the drug you can use the prednisone. Epsiximab induced thrombocytopenia, the platelet transfusion required. And for the heparin induced thrombocytopenia, all forms of heparin must be discontinued, and you can prescribe alternate anticoagulant, that is ergotroban or bivalirudin or fondaparinux or warfarin. Please join again just for a few minutes, because the meeting will be discontinued within a minute. So please join again.